See, what is chronic myeloid leukemia? Leukemia always refers to what? Some kind of a neoplasm, right? It is cancer, it's neoplasm. So leukemia is something to do with the blood. So this is going to be the blood picture, okay? So basically you can see RBCs here. So this is a lymphocyte, correct? Are you able to see? So this is the blood picture in which you have metamyeliocytes and myelocytes coming in. That means what shouldn't come from the bone marrow has come off to the blood. Okay, so what are these RBCs? This is a small lymphocyte. This is a neutrophil. This is an eosinophil. This is the basophil. All this much is normal, right? In normal peripheral smear, you will see all these. But look at this. Myelocyte, metamyeliocytes have come off to the blood. So this is what is chronic myeloid leukemia. First of all, if you don't know anything that is being spoken of, then understand this much. First of all, how is blood made, right? So erythropoiesis. So look at this. There is a this is a potential hemopoietic stem cell. So this is a hemopoietic stem cell. That means it will give rise to blood things. So hemopoietic stem cell, hemopoietic stem cell it is. Now that can become either a myeloid cell or a lymphoid progenitor. So it can become a myeloid progenitor or a lymphoid progenitor. Now let us look only at myeloid. See, lymphoid will give rise to lymphocytes. Okay, so forget about that picture. Here come to myeloid. Here we are focusing on chronic myeloid leukemia. So you need to understand this picture. So myeloid progenitor can give rise to RBC or WBCs or platelet, but not the lymphocytes. So in WBCs you usually include the lymphocytes, correct? But here we are not including the lymphocytes. All the WBCs except the lymphocytes. So the WBCs will be like neutrophil, eosinophil, basophil, and even monocyte. Now myeloblast, here you have promyelocyte, myelocyte, metamyelocyte. So myelocyte and then metamyelocyte. So then you have a neutrophil band form, then you have neutrophil. See, what should be in the blood? In the blood you should have neutrophil. You should not have these precursors. You should not have myelocyte, metamyelocyte, you should not have. But what you are seeing in the blood picture of chronic myeloid leukemia, you are seeing myelocyte and metamyelocyte. If you see myelocyte, metamyelocyte, that means it could be chronic myeloid leukemia. A very, very vague, a very high level we have told you, okay? Let's go to the details later. Now we have finished looking at the hematopoiesis. Now let us look at what myeloid. See, myeloid stem cell can become everything except a lymphocyte. So it can become an RBC, it can become granulocyte, or it can become platelet. In the process of becoming a neutrophil, it will become a myelocyte, metamyelocyte, etc. Right? Now, myeloid neoplasms. You have neoplasms which can be myeloid neoplasm or lymphoid you can have. So you can have myeloid or lymphoid. Now in myeloid, you have all of these. What and all you have? Chronic myeloid leukemia. So this is a myeloproliferative disease. This is a myeloid neoplasm. In that you have myeloproliferative disease. Like that you have a lot of other things. So just focus on chronic myeloid leukemia. That is the only job given to you at the moment. Tell about chronic myeloid leukemia. So it is a myeloproliferative disease. It is a myeloid condition. Okay. What else you should know? Main things are like it is caused because of translocation of chromosome 922. It is called as Q3411 BCR ABL positive. Philadelphia chromosome will be there. This much if you know, more than enough for now. Okay. So people, let us look at the Philadelphia chromosome now. Okay. So just pay attention here. Now what happens? There are two chromosomes involved. Which are the two chromosomes involved? 9 and 22. So here you can see 9 and 22 are involved. This is normal how it should be. ABL on 9 and BCR on 22 chromosome. 22, the number chromosome. Chromosome 22 should have BCR. Chromosome 9 should have ABL. But what happens? In the Philadelphia chromosome, this ABL portion from 9 comes and sits on 22. So there is a BCR ABL fusion gene. So BCR ABL becomes positive in this person. Okay. So where is this BCR ABL? On the chromosome 22. So you will see this translocation. Look at this. T, that is translocation 9 semicolon. All are semicolons. Pay attention here. 9, 22. 9 is going to 22. 9 portion is going to 22. What is going? Q. Q is the long arm, correct? P is the petite, the small arm, and Q is the long arm. So the changes are only on the long arm. Long arm 3411. Not sure what that is, okay? BCR ABL positive. So Philadelphia chromosome. We have finished. What are we looking at? We are looking at chronic myeloid leukemia. So let us get to the theory now. Okay, so just pay attention here to the clinical features. Now what will be the clinical features in this case? So just remember anemia. So very easy to say anemia. Weakness, pallor, dyspnea, tachycardia, splenomegaly also you can say. Bleeding tendency, everything to do with blood. And in the juvenile CML, there will be lymph node enlargement. This also, if you want, you can mention. So these are easy things to mention, right? Now let us move on to lab findings. CML lab findings. See, in blood picture, what you will see? Anemia, right? Anemia you will see. Then you will see that WBCs are more, right? So you will see leukocytosis, okay? There will be 2 lakh per microliter. Wow. Okay, then you have 3 phases are there in CML. Chronic, accelerated and blastic. Interesting. In chronic, again they have put chronic. In chronic CML, what happens? There will be more myelocytes, metamyelocytes, more neutrophils also will be there, right? An increase in the proportion of basophils up to 10% is a characteristic feature of CML. So basically, increase in basophils can mean CML. Increase, okay, if there is a rising basophilia, it means it is becoming blastic, okay. Then, now let us go to accelerated phase. In accelerated CML phase, increasing leukocytosis and splenomegaly. Platelets can't be trusted, either ways they can play. Okay, then moving on. Let's go to the blastic phase of CML. Now in blastic phase of CML, what happens? The blasts are more, obviously, right? The blasts are greater than 20%, greater than or equal to 20%. So what are these blasts? Blast cells can be myeloid or lymphoid or erythroid or undifferentiated. They can be anything, okay? And in this myeloblasts, if there are myeloblasts, there will be no OR rods, okay? So these, what can these blasts be? These blasts can be myeloid or lymphoid, okay? They can be myeloid or lymphoid. That covers even erythroid, so we don't want to actually add that here. Myeloid or lymphoid, okay? Or it can be undifferentiated blast also. Now, if there are myeloblasts, okay, if there are myeloblasts, they will not have OR rods like in AML. In AML, they will have OR rods, right? In acute condition, they will have OR rods. But in chronic myeloid leukemia, myeloblasts will not have OR rods. So, OR rods will become a distinguishing criteria for you, correct? Platelets, no, can't trust. Either they can be more or less, or sometimes they're saying more, sometimes they're saying less, sometimes they're saying normal, can't be trusted. So blood picture over. Now let us move on to bone marrow findings. CML lab findings. Let's go to bone marrow. Bone marrow. Okay, let us look at the bone marrow picture. Obviously, it will be hypercellular, less fat. Myeloid cells will be predominant. Increased myeloid erythroid ratio. This is not at all difficult for you to say. Coming to erythropoiesis, there is reduction in erythropoietic cells. See, the predominance will be taken by the neutrophil, premature cells which form neutrophils, like the myelocyte, metamyelocyte, correct? So the myeloblasts also could be more. Megakaryocytes will be small in size. The number is unpredictable. These platelets, they can play anyways, this side or that side, we don't know. Reduction in erythropoiesis. What is more? Increased myeloid erythroid ratio. Bone marrow is hypercellular. Okay. Now let us go to cytogenetics, the Philadelphia chromosome. Hold on. So basically you can detect the Philadelphia chromosome either by FISH technique or by PCR. What is FISH? Tell the full form of FISH. Fluorescence in situ hybridization. This is for detecting the chromosomes, okay. So that one you can use, or you can use PCR to detect this BCR ABL fusion gene, okay, to detect the BCR ABL fusion gene. You can use this technique. So how is this caused? Why is this caused, this Philadelphia chromosome? Either because of reciprocal translocation, which can be either balanced reciprocal translocation or unbalanced reciprocal translocation or Robertsonian translocation. Because of all these, this Philadelphia chromosome can come, okay. What actually is shown here, I think, is the reciprocal, balanced reciprocal translocation, okay. So what happens? Translocation between the long arm of chromosome 9 and long arm of chromosome 22. Okay, so this is the Philadelphia chromosome. Mostly it is the balanced reciprocal translocation, which is shown here is the balanced reciprocal translocation. Okay. Robertsonian translocation is actually some acrocentric chromosomes at the centromere with the loss of short arms. Something very complicated to do with the centromeres, etc. Anyways, what's shown here is the balanced reciprocal translocation. You can remember that. So you will have a BCR ABL fusion, and that too in 90 to 95% cases only. This is very weird. I don't know what happens in the other 5% people and how they are calling it, okay, CML. Now inhibits, what is this BCR ABL fusion gene? This inhibits apoptosis. So basically, there can be no apoptosis. The cells go on dividing, right? There is no death for the cell. So basically, you might think, oh, cell won't die, that's great. No, but this will cause cancer, correct? Lot of blasts in the blood picture, lot of unwanted cells, correct? That is what is leukemia. Lot of details given here, okay? So the other thing about cytogenetics you should know is that how a phase, the second phase, what is the second phase that we have seen? Accelerated phase, how it becomes a blastic phase, how exactly it lands up becoming a blastic phase, you know. Here, there can be, the tumor suppressor genes can get suppressed, like the P53 can get suppressed, the RB gene can get suppressed, the RAS oncogene alteration will be there, MYC oncogene will get altered, cytokines can be there. Okay, let's look at all that, hold on. So here now what else can happen? Why it becomes blastic? Blastic phase is due to, okay, suppression of P53, that is the tumor suppressor itself gets suppressed, RB genes get suppressed, right? So alterations, you can say alterations of tumor suppressors, correct? Then alterations in, are you able to see? Alterations in RAS, MYC, oncogenes, correct? And then you have release of cytokines, that is like IL, interleukin 1 beta. Not sure what this is, never heard, but definitely progression to blastic phase may be due to, okay, alteration in tumor suppressors, that is P53, RB, alterations in the oncogenes, RAS oncogene and MYC oncogene, okay. How much went into your head and how much went over your head? Something went inside. So basically these are cytogenetics, more like pathology, pathogenesis. Philadelphia chromosome because of balanced reciprocal translocation which can be detected by FISH, PCR. FISH is nothing but fluorescence in situ hybridization. Then you have the ABL, BCR ABL, guys, just say BCR ABL because B is first here, BCR ABL fusion. So what will happen, the ABL BCR is actually oncogene, but this is BCR ABL fusion they are seeing. So ABL will create more tyrosine kinase enzyme, so this will inhibit apoptosis and a lot of binding happens of ABL to so many things. Blastic phase may be because of further suppression of the tumor genes P53RB and also because of RAS NYC oncogene proto-oncogenes. Those proto-oncogenes get altered. Then you have release of some cytokines. If you want, you can remember the details. Moving on, guys. Cytochemistry. Now, cytochemistry, what you will see that the NAP score has become less. What is NAP score? Neutrophil alkaline phosphatase has become less. Why this NAP score became less? Because probably the blast cells are more. So, the neutrophil alkaline phosphatase becomes less. Now, other findings you will see hyperuricemia. Hyperuricemia or gout you can see. Why you are seeing hyperuricemia? No idea, but actually we have seen in clinical features. If you remember, in clinical features we have seen gout, correct? So that shows that hyperuricemia can be there. Let's move on. Last slide here, treatment of chronic myeloid leukemia. So what and all treatment you can give? You can remove all the malignant clones, okay? That is the nice, na? And then you can do bone marrow transplant, chemotherapy. All these are standard things you will write for neoplasia. Splenectomy or irradiation of spleen. Something like this was written in the textbook. And Imatinib induces apoptosis of this BCR ABL positive cells. This is the only unique thing that you have to know. Imatinib, okay. So actually Imatinib, right, it is a anti-cancer drug. It comes in the targeted drugs actually. It's a targeted drug. Targeted anti-cancer drug. Okay, and it is a BCR ABL tyrosine kinase inhibitor. Okay, so in pharmacology you would have read about this. That's all right. So we are done with the chronic myeloid leukemia. Almost everything that we want to know about it. Just draw this diagram in the exam. See, this much of it is anyways normal. Hold on, we'll mark it for you. See, this much you draw normally, okay, the blood picture. Here you have RBC and small lymphocyte, neutrophil, eosinophil, basophil. In extra what you have to draw in the blood picture for CML, you have to draw myelocyte and metamyelocyte. Myelocytes will be like this and metamyelocytes you draw a half moon shaped cell like this. And you will have a lot of neutrophils. That's all for now, guys. We have covered this beautiful topic, chronic myeloid leukemia, which will be very useful for you in theory and practical. Okay? Bye-bye.